Today I wanted to break down two non-invasive tests for endometriosis you'll be hearing a lot about in the UK, the Endosure test and the BSGE Endotest. Both have just been added to the recommendations by NICE in their early draft as a guidance to be used across primary care, so your GP practice in the NHS, specifically for women where endometriosis is strongly suspected. But examination and imaging such as ultrasound scan or an MRI are normal or inconclusive. Now, they are not screening tools for everyone with a period pain, and they are not designed to replace a thorough clinical assessment or laparoscopy. The Endotest is a saliva-based test. It analyzes microRNAs, so those tiny non-coding RNA molecules that appear to have a specific signature in people with endometriosis. The saliva sample is collected, it's sent to a central lab, and the results come back to the clinician after laboratory processing, and that usually takes several days to weeks. The Endosure test is a functional gut-based test. It cannot be done whilst you're on your period, and it uses sensory pads placed on the abdomen to measure electrical signals from the gastrointestinal tract while you're in a controlled fasted state. The idea is that endometriosis, through pain, inflammation, and neural crosstalking between the pelvis and the gut, produces a recognizable pattern of intestinal electrical activity. Both tests are non-invasive, designed to support early decision-making in primary care, so your GP practice, especially when ultrasound scan expertise is variable in your area and access to gynecology and laparoscopy is slow. Rightly so, a lot of you asking about what about the accuracy. Now, when we talk about accuracy, we need to separate sensitivity and specificity. And remember that these numbers come from a selected study population, often under ideal research conditions. So for the Endosure, published data reports sensitivity, so a true positive rate, in the region of about 96 to 99%, and a specificity rate, so a true negative rate, of around 94 to about 99% when compared with surgical findings. But the Endotest, so for that, studies report sensitivity in the range of roughly 91 to 96%, with specificity around 95 to 96% compared with a laparoscopy. Now, on paper, these numbers are extremely impressive and far better than many of the tools we have traditionally used in this space. However, I need to reiterate that they are not 100%, and they are derived from specific study cohorts. So in real world primary care performance, actually it might be that we get lower numbers due to the spectrum of the effects, comorbidities, and a variation in how these tests are implemented. And it's for that reason both NICE and most independent clinicians view these as high quality decision support tools, not standalone definitive diagnostic tools or replacement for a surgical confirmation that is still required. The biggest issue I have with endometriosis care is access, and these tools are positioned as maybe a way of shortening the diagnostic odyssey. Yet in many areas, women are still facing 1 to 2 years wait for assessment and management in gynecology or endometriosis centres. A positive test does not magically create capacity in secondary care. It simply adds more weight to the argument that someone needs a timely review. So while these tests may help clarify risk earlier, without investment in specialist services, surgery lists, and multidisciplinary care, we risk having highly accurate tests feeding into an overwhelmed pathway, and women are still sitting in the system without an accurate treatment plan, and the disease is able to progress and have the ramifications that we see currently. And while we're talking about innovation, it's worth mentioning an emerging line of research that may help explain why some treatments work better than we'd historically expect. Traditionally, endometriosis has been seen as a strongly estrogen-driven condition. Estrogen promotes proliferation and survival of ectopic endometrial-like tissue. So it's not the lining of the womb, but like tissue, which is why many treatments have focused on suppressing estrogen. So newer data, including work on steroid hormone profiling, suggests that there may also be an altered adrenal androgen production in endometriosis, so the androgenic effect, rather than a purely estrogen-centric story. This research is still signal-level evidence, not definitive proof, but it fits with several clinical observations that I've noted as a clinician. Firstly, combined oral contraceptive pills with a stronger anti-androgenic profile often appear particularly helpful in those patients who have endometriosis symptoms. And also progestogen-only options such as desropenenol or SLIND, which has both progestogenic and anti-androgenic properties may actually be more effective for pain and bleeding in some people with endometriosis. This doesn't mean androgens cause endometriosis in a simple way, but it does suggest the hormonal environment, including adrenal androgens, is more complex than estrogen high, progesterone low. And also, this is emerging research, but we do need more of it, and it may change how we can individualize hormonal treatment choices in the future. If you stuck with me so far in this really long video, thank you. And to summarize, the clinical take-home points is that Endosure and Endotest are promising non-invasive, highly accurate decision support tools for suspected endometriosis, particularly useful when examining and imaging are non-revealing but clinical suspicion remains high. Also, their reported sensitivities and specificities are high, but they're not perfect, and real-world accuracy may be lower than in tightly controlled studies. So just watch out, and if you get a negative test, does not mean that you don't have endometriosis. They should also be used within a structured diagnostic pathway, not as a standalone yes-no answer. Their role in adenomyosis, so does the Endosure or the Endotest work for adenomyosis, is currently limited, and company-quoted accuracy figures show that actually interpretation should be made with caution until more independent data is available. Now, major barriers remain around surface capacity and access. A positive test still needs a functioning referral system to make a difference. And also, finally, emerging research on androgens in endometriosis is reshaping our understanding of the disease's hormonal drivers and may help explain why certain anti-androgenic regimes are specifically and particularly beneficial, but these findings are early and we need replication. So technologies are great. It can help shift endometriosis diagnosis earlier in the pathway and reduce the number of people who wait for the best part of a decade to be believed. So I guess in that way, it stops the gaslighting and also supports women because we're thinking about endometriosis. But they are tools, not magic bullets, and they must be embedded within high quality patient-centered care. And my concern is that would be the case. And yes, I welcome every innovation and I welcome your thoughts on this as well. But this is why I think that whenever we get tools, I'm always going, it has to come with access. It has to make sure that everybody's getting equal choice. And also we need to make sure that they're accurate. There's no point having a test which isn't accurate for the wider public, because all you've done it is in trial data. The numbers can look amazing, and of course they're going to look amazing, and the marketing around it looks amazing. Anyway, leave me your thoughts. I just thought I'd put that down, and well done for sticking with this video because I know it's really long and I'm really tired.